good evening, afternoon, everybody, depending upon where you are. We're going to talk today about the treatment of early Parkinson's disease. I'm going to present the evidence for early treatment, and we'll discuss various therapies. So everybody's aware that Parkinson's disease is a chronic progressive neurodegenerative disorder typically characterized by loss of dopaminergic neurons, among a whole host of other neurotransmitters involved, but dopamine still remains the main neurotransmitter we certainly target with therapy. And there's a loss of dopaminergic neurons in the substantia nigra, and the typical clinical features include arrest tremor, cogwheeling rigidity, bradykinesia, slowness or paucity of movement, akinesia. And as the disease progresses, postural instability. And many of these patients may actually present much earlier with non-motor complaints, constipation, orthostasis, urinary frequency, impotence, and we frequently see patients with depression and with more advanced disease, the possibility of cognitive impairment or dementia. Now, a very interesting paper was published several years ago by two German pathologists, Brock and Brock, and they looked at a bunch of post-mortem PD brains and qualified the progression of abnormal pathology. And interestingly enough, the earliest part of the brain that was involved was the dorsal motor nucleus and the olfactory bulb, and clearly as the disease progresses, clinically balance becomes impaired, cognitive decline becomes an issue as the abnormal pathology spreads over time. So the real question that we face when we see patients clinically with early disease is, when do we start therapy? Do we wait until they're bothered by their symptoms? Do we wait until patients present with significant functional disability? Do we wait until they say, I really need to be treated and are significantly impaired? Or do we treat patients as soon as we can make a diagnosis? And this is really the point that I'd like you to take home from this lecture, that the evidence, the preponderance of evidence really suggests that we need to treat patients as soon as we can make the diagnosis. Now, all of you learned in whatever specialty school you went to, medical school, pharmacy school, etc., that Sinemet or carbidopa, levodopa is the most effective therapy for Parkinson's disease. And decades down the line from its advent, use in Parkinson's disease, this remains a true statement. It is the most effective medication that we have and remains the gold standard. And in fact, surgical therapy is held to the gold standard of best effect, best benefit with levodopa. There is no therapy we can offer patients that show better improvement, at least with regard to motor function, than levodopa. However, there are problems over time. Initially, patients may have nausea and orthostatic hypotension, but over time, patients develop motor fluctuations in the way of wearing off, which is the first motor complication, and that is typically a patient will say, well, I took my Sinemet, I take it 3 times a day, and I initially got 4 or 5, maybe 6 hours of good benefit. Now, a year later, my medicine is wearing off. An hour before it's time for my medicine, I don't even have to look at my watch. I know because my tremor comes back, I become stiff, slower. So wearing off is the earliest motor fluctuation, and then dyskinesias or abnormal involuntary movements is the other most common motor fluctuation that we see with the use of Sinemet.